Okay, this recording is going to start with slide 31 and go through the end of the Parkinson's drugs. We are going to be finishing up the seizure medications, anti-seizure meds, talking about some of these. One thing to note is that all anti-seizure medications are known for increasing the risk of suicidal thoughts and behaviors. We do need to be carefully monitoring for new or worsening depression, suicidal thoughts, mood changes, and we need to make sure we educate the patient to report any suicidal ideations immediately. They do have significant adverse effects in pregnancy. Again, this is going to be a risk versus benefits situation. We have to weigh whether or not the risk to the mother is worth abstaining, or usually we will continue the medications, especially with a lot of these newer medications. Um, they do often always, most of these medications also cause significant GI side effects, especially nausea, vomiting, diarrhea. If the patient takes them with 6 to 8 ounces of fluid, this will often minimize the GI upset. They are going to be contraindicated in the presence of drug allergy or pregnancy. Again, though, we're monitoring that risk versus benefit for the pregnancy. Let's see if I can turn this sideways for you guys. There we go. There we go. All right, phenobarbital, slide 32. This is one of the frontline medications used for treating status epilepticus. It is for tonic-clonic seizures. It is a GABA-mediated drug, so it has a brain inhibitory effect. It does have a narrow half-life, narrow therapeutic range, like most of these seizure medications. It is going to be having toxicity symptoms greater than 40 micrograms per milliliter. It is a preferred medication used in third world countries and the drug of choice because of its very low cost. Also, it is able to be dosed once a day, which improves patient compliance. Its most common side effect is going to be sedation, but they do typically develop a tolerance to that with continued therapy. So that usually improves after a couple weeks. It is going to be contraindicated in liver and kidney disease as well as respiratory illness. Again, one of our major side effects for this medication is sedation, right? So we're going to want to be careful with respiratory illnesses. It does have to be diluted with saline and pushed very slowly. We did a drug calculation on this on the board the other day. It does have significant extravasation potential. And so we are going to inject 0.5% procaine into the local area as an IV infiltrate antidote for these medications. It does need to be very carefully and slowly pushed. If we push it rapidly, it can cause hypotension and marked respiratory depression. We would need to stop the infusion if that occurred. Let's see. There we go. All right, barbiturates. These drugs are going to interact with any medication that causes CNS depression. So alcohol is going to be a major no-no here. Enzyme induction as well. So any drugs, barbiturates are a major inducer of the P450 enzymes. So because of this, it can cause more rapid clearance of the drugs listed on page 219. It's going to cause that increased metabolism of those medications, especially our MAOIs, our tricyclic antidepressants, anticoagulants, and oral contraceptives. So we would need to have a backup oral contraceptive if they were on a barbiturate as well. When we are assessing these patients, we definitely want to note any complaints of insomnia with this, especially paying attention to when the medication began. We're paying attention to their sleep patterns to begin with. We don't want to interfere with their natural REM cycles. We are looking at blood pressure, especially standing and supine. They are at risk for some orthostatic vital signs when receiving these medications, especially those barbiturates. We always want to do a baseline comparison so that we know where they're starting out with and whether or not we are achieving a therapeutic effect. Any changes in mental status, such as suicidal ideations, need to be reported immediately. And we also always want to be assessing their alcohol, tobacco, caffeine intakes, as well as other medications they may be on. See, there we go. All right, phenytoin. So this is going to be one of our first line treatments for seizures, and it is our prototypical drug for epilepsy. It is used for tonic-clonic and partial seizures. It is going to be contraindicated in any heart conditions that involve bradycardia or have the heart blocks is going to be a contraindication. Some of the side effects are drowsiness, lethargy, confusion. Gingival hyperplasia is the big one. On the next slide, you'll see a good picture of that. We really need to educate our patient to be doing really excellent dental care in order to prevent gingival hyperplasia. We do want to assess their oral care regimen and oral cavity as well, making sure we are monitoring for that. Again, very, very narrow therapeutic range for this medication. With toxicity, we are going to see nystagmus, ataxia, dysarthria, and potentially encephalopathy. It is also going to have a potential side effect of a measles-like rash that we would want to make sure the patient is reporting. We do need to monitor any liver functioning. It is going to increase the metabolism of other medications because it is highly bound to plasma proteins. High phenytoin levels with low serum albumin concentrations will occur as well. So think your liver patient, your chronic renal failure patient, and your malnourished patient, and they don't have those enough albumin in their system, and then we see high phenytoin levels that are a result of that. One reason that phenytoin is preferred is because it can be given daily or BID dosing, so it is going to improve patient compliance because of that long half-life. We do need to dilute this only with normal saline. It is going to cause severe soft tissue irritation and inflammation with or without extravasation to that vein. This is our gingival hyperplasia slide. With this, we want to do a history of the existing seizures. We're always going to initiate seizure precautions on these patients, carefully watching for our IV infiltration because it can cause a lot of extravasation and irritation to the local areas. We are only going to dilute this with normal saline. It must be given very, very slowly, no faster than 50 milligrams per minute. We do need to monitor for bradycardia, decreased blood pressure, or dysrhythmias. If those occur when you are pushing this IV, you need to stop that infusion immediately, monitor their vital signs, and notify their provider as soon as possible. We want the patient to understand that they should expect a little bit of sedation. We do not ever omit a dose or stop abruptly because that can lead to additional seizures. And we do need to monitor the blood levels or the potential seizures can occur. Patient teaching should always include to document the type and character of the seizure, and then we as medical providers are going to do that also. Come on. There we go. All right, valproic acid or depakine. This is also frequently called Depakote when it is the divalproic sodium. If it's valproic acid, it's the depakine. If it's the divalproic sodium, that's going to be our Depakote. That Depakote is a long-acting. It is often available in this sprinkle form, which is really awesome. It can be sprinkled onto food and well tolerated, whereas the valproic acid comes in a syrup form and can be just drunk by the patient. This is going to be used to treat generalized seizures as well as bipolar disorder. It is going to be contraindicated in liver impairment patients, and it is going to increase the level of GABA in the system. Come on, there we go. Side effects are going to include drowsiness, nausea, vomiting, and GI upset. They may have some tremors, weight gain, and hair loss. The most serious are going to be hepatotoxicity and pancreatitis. So we would not want to give this in our liver failure patient. For our gabapentin, so remember, GABA is going to inhibit brain activity. So when this gabapentin or neurontin is going to be a chemical analog of that GABA neurotransmitter. It is going to be an adjunct treatment for partial seizures and prophylaxis of partial seizures as well. It is shown to be an effective medication for treating new onset epilepsy, and it is one of the most classic medications used for neuropathic pain. especially associated with the diabetic peripheral neuropathy, as well as fibromyalgia. Some side effects can include some dizziness and drowsiness. This is one of the few seizure medications that can be taken without regard for meals. For our carbazepine or Tegretol, this is the second most commonly prescribed anti-seizure med. It is used to treat trigeminal neuralgia as well as anti-seizures in general. It is chemically related to tricyclic antidepressants. It has many, many drug interactions. It is the first-line treatment for partial seizures and tonic-clonic seizures, and contraindicated in absent seizures and bone marrow depression. Like I said before, it has lots of drug interactions, which you can find in Table 14.5. Its side effects can include some ataxia, headache, dizziness, drowsiness, as well as visual changes. It also has lots of food interactions, especially with grapefruit juice. This will increase its serum levels and the drug effect. So it's going to increase the potential toxicity with grapefruit juice. Again, grapefruit juice doesn't play nice with a lot of medications. It is going to affect the metabolism of those medications. It decreases the metabolism of some drugs, such as the drugs for erectile dysfunction, estrogen, benzodiazepines, raising the levels of them in the blood. And it increases the risk of toxicity with some of these other medications, but decreases digoxin and fexofenadine by decreasing the absorption from the intestines, which you can find on page 90. All right, nursing implications. We always want to do a thorough physical examination, paying attention to possible drug allergies, adverse affections, reactions, contraindications. We do want to know what type of seizure disorder they have. That is going to direct what type of medication we use, as well as any precipitating events they might have. We want to know how long the seizure lasts, how frequently they get them, how intense they are. We want to know any auras they might have before they come on. Any bowel or bladder incontinence that occurred during the seizure, any loss of consciousness, any falls. We always want to do a renal liver functioning as well as CBCs. Some of these medications can interfere with the CBCs and cause some anemia, so we want to make sure that they are not having any issues with that. And then moving into Parkinson's disease. I'm not going to go crazy into the patho of this because you've already had that in patho. And I know Trent talked to you a lot about that as well. As far as the main things we're thinking about, the symptoms are going to be associated with dopamine deficit and acetylcholine excess. So we want those to be in balance for the regulation of the posture, the muscle tone, and voluntary movements. With Parkinson's, there is a loss of dopamine, which is not noticed until 70 to 80% of the dopamine is lost. So 70 to 80% of that is lost before we even know that the patient has symptoms. A lot of times they will experience a tremor at rest or this pill roll tremor. That is the presenting sign in 70% of patients. They often will also have a mask-like facial expressions. They may have some slow movement, some rigidity, unsteady posture. And 40% of them will also experience psychosis and hallucinations. I am going to pause this real quick if I can. Oh my goodness. Hang on. We'll get back in a second. Okay, sorry about that. All right, we are on slide 41, I believe this is. So we are, 47. All right, so we're talking about some of the management of Parkinson's. So we are not going to be able to reverse the degeneration that has already occurred. Our goal is to slow the progression and control those symptoms. We want to try to balance the levels of dopamine and acetylcholine in their bodies. And we want to improve their activities of daily life. That is one of the main things we're wanting to achieve. We can do this through some dopaminergic agents as well as anticholinergic agents. As far as anticholinergic medications, these are going to be drugs that are blocking the effects of acetylcholine. That's why we're using them. So as the dopamine decreases, the acetylcholine increases, and we're going to have an increase in the muscle tremors and the rigidity. So we want to reverse that effect, decrease the pill rolling and the head bobbing that occurs. Benzotropine is going to be a secondary drug that is used for tremor and muscle rigidity. We can also use Benadryl for the same effect because it is an anticholinergic medication. We do need to educate the patients that it might take several days to weeks to see improvement in the symptoms. It's going to be divided into 1 or 2 doses per day. And we do need to be very careful in hot weather because of that anticholinergic effect. We want to use it cautiously in hot weather or during excess exercise, especially in the older adults, because it can cause some hyperthermia. Adverse effects can be tachycardia, confusion, disorientation. They can cause urinary retention, as well as dry mouth. That is one of the most common complaints with these anticholinergic medications is dry mouth. In order to combat that, they can take it with a little bit of fluids, take it with increasing their fluids throughout the day, as well as take it with some hard candies that can help. As far as the GI upset that it can cause, they can take this with a snack. A ginger ale or ginger tea is actually a great choice. We do want them to take it late at night because of the sedating effects. And then we would be very, very cautious using this in the presence of other anticholinergic medications because of the risk of anticholinergic syndrome. All right, so our levodopa, drugs that affect dopamine. So levodopa is going to significantly metabolize before it reaches the brain. Dopamine does not cross the blood-brain barrier. It can cross as levodopa and then convert to dopamine. However, even if we are giving levodopa, it is significantly metabolized before reaching the brain. So we combine that with carbidopa because carbidopa prevents the breakdown of levodopa in the bloodstream, and more of it can get to the brain. Neither of these cross the blood-brain barrier, though. That's part of why we give them in conjunction, because this carbidopa is a levodopa enhancer. And one of the benefits of that is that it allows for lower doses of levodopa being used, and reduces the side effects that are associated with high dose levodopa therapy. Carbidopa levodopa, or Sinemet, is one of the most effective Parkinson's medications. We are going to use this as soon as the patient becomes functionally impaired. This is the drug of choice for most older adults. 75% are going to experience a 50% decrease in symptoms. It does take several months for it to actually start to work. It is not going to, again, it's not going to prevent the progression of the disease. It's just going to slow it down. It is an oral medication and absorbed well in the stomach. There is a lot of food teaching that goes along with this, which we'll talk about in this next slide, but they really need to avoid high protein foods around when they are taking the carbidopa levodopa. So lots of its side effects include nausea, vomiting. This is improved if we start with a lower initial dose and then taper them up. They can get some cardiac dysrhythmia, some hypotension, muscle cramps, and GI distress. It is best on an empty stomach, but they can take it with a little bit of food if they do want to minimize the GI upset. As far as cardiovascular, it can cause some postural hypotension. We want to teach them to change position slowly. It can cause some psychosis as well. About 20% of patients experience that. We do want to let them know that it will darken their sweat and urine. This medication can also have some risk for overheating, especially when taken with those anticholinergics. So we want to avoid the excessive exercise or heat exposure. They a lot of times will complain of, the overheating is just with the anticholinergic meds. As far as drug interactions, they do interact with antipsychotics, MAOIs, anticholinergic drugs, because that enhances the levodopa. High doses of vitamin B6 and or iron can also interfere with levodopa. This is prevented if it is combined with carbidopa. The food interactions, high protein snacks or meals can decrease the absorption of the medication. Because of this, we need to make sure that they have a half hour before their medication or an hour after their medication before they take those high protein snacks. If they are starting to complain of a lot of these, if they are complaining of side effects or saying that their medication isn't working very effectively, and then we note that they are taking some iron or some vitamin B6 or a high protein diet, we would want to change what type of snack they're taking or space it out more so that they are not taking that high protein snack close to the administration of their Cinemet. Whenever we are assessing, one of the primary things we are watching for is whether or not the medication was effective. So did we achieve a therapeutic effect? Are their symptoms actually improved? We are paying attention to the vital signs. We're monitoring for that postural hypotension. We want to monitor for dizziness and hallucinations. Whether or not they've had a decrease in their bradykinesia, their improvement in their posture, a decrease in their rigidity and tremors. A lot of these medications can cause drug-induced urinary retention because of the anticholinergic effects that are occurring. We also want to make sure that we tell the patient to give them several hours before the bedtime for the Cinemet to prevent insomnia. We do want them to immediately report any excessive twitching, drooling, or eye spasms that can indicate a potential overdose. These medications do have a on-off and wearing-off phenomenon. So on-off is whenever the disease is worsening when too little dopamine is present. This can be exacerbating by missing the dose by even 30 minutes. If a patient does miss a dose, we need them to contact their provider for additional guidance. We are not going to say whether or not they should take the next medication. That's going to be provider dependent. And then the wearing off phenomenon is that the worsening Parkinson's symptoms are going to occur as the drugs lose their effectiveness. Sometimes this is given in conjunction with vitamin B6, that pyroxidine, because it does reduce the activity of levodopa. But since most patients take it with carbidopa, that's not really a concern. And it is responsible for the peripheral nerve skins and mucous membranes. All right, now we are going to stop here, and there will be an additional recording for your psych drugs.